Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 58th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the Adult Program Coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Advancements in Knee Replacement, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. We all know someone, if not ourselves, who has had their knee replaced. Some folks have had both knees done, and yet others have had multiple knee replacements. The advancements in total knee replacement surgery since the first was performed 56 years ago have greatly increased the effectiveness, patient reach, speed of recovery, and return to function for patients receiving this potentially life-altering medical procedure. One of the most fascinating advancements to me is the fact that total knee replacements can now be done as an outpatient procedure. In fact, tonight, Illinois Bone and Joint Institute's Jeremy Oryhon, MD, will help us understand total knee replacements, the benefits of outpatient procedures, essential preparation steps, and the recovery process following a total knee replacement. Dr. Oryhon will provide insights into the latest techniques, help us discover how outpatient total knee replacement can improve quality of life with a quicker recovery and reduced hospital stay, and clear up some of the misconceptions about knee replacements that are floating around. Dr. Oryhon is a board-certified orthopedic surgeon who began his practice in 2009 after completing a fellowship in joint preservation and replacement orthopedic surgery at Washington University in St. Louis. He has a wide range of experience, including but not limited to minimally invasive hip replacement, hip resurfacing and arthroscopy, treating problems with the young adult hip, Oxford partial knee replacement, muscle-sparing total knee replacement, and employing and keeping up to date with the latest minimally invasive techniques and technologies. Dr. Oryhon finds that he is mostly seeing older patients with hip and knee arthritis who really just want pain relief and to return to their everyday functions. He believes it is very important to partner with his patients and to educate them about the disease process, their particular disease, what can and cannot be done for them, and the options available to help them achieve their goals. Dr. Oryhon says his philosophy rests on 4 pillars: partnering, education, treatment plan execution, and recovery. He says that he finds incredible joy and satisfaction in seeing his patients recover from their hip and knee arthritic diseases, being relieved of their pain and functioning so much better. To Dr. Oryhon, it is an incredible honor and a privilege to take decades of medical and orthopedic knowledge that are available to him and to integrate them into the care of his patients. During Dr. Oryhon's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Oryhon immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Oryhon via one of these options that will be listed on the slide shown during the question and answer portion at the end of his program this evening. One last thing before I turn the evening over to Dr. Oryhon, please mark your calendar for our next IBJI and YMCA Education Series program on Tuesday, November 12th at 7 p.m. Dr. Mehul Gurala will discuss managing low back pain. Thank you again for joining us tonight, and thank you to Dr. Jeremy Oryhon for your time and effort in putting together this program to discuss knee replacements and advancements. And Dr. Oryhon, please take it from here.
All right, thank you very much, Karen. That was a very nice introduction, and really appreciate it. And welcome to everyone. I can't see you, but I know you're there, and I welcome you all. And I don't know how many have done these before, but this is my first one, so welcome, and we'll get started. So Karen had a nice introduction, and I thank her for that. Here's where I've been. I grew up in the southwest suburbs. It's called Homer Glen now, but so I'm around Chicago area, born and raised, and started practice in Barrington 15 plus years ago. So I went to U of I and Rush and started my residency at Tulane, but then a little hurricane called Katrina hit, so I finished at Vanderbilt and moved on to WashU, and I've been in Barrington for the last 15 years, and I see patients in Barrington and Crystal Lake, and operated Advocate Good Shepherd and a surgery center. So tonight we'll talk about advancements in knee replacement and specifically understanding the outpatient benefits, preparation, and recovery. So I know that there are a lot of webinars that have already occurred. There's 58 on there, and I've highlighted a few of the specific knee webinars that have been done by my colleagues, and they've done an excellent job. So they've gone through a lot of the disease states already, the different pathologies we see at the knee, and the different treatment options for various knee problems. So also you'll find anatomy, you'll find surgical options there. So as I said, we're going to focus more on knee replacement benefits and outpatient preparation. And so you can refer back to a lot of these other webinars for other specifics if I don't cover them tonight. But I do want to start out just with a little refresher of anatomy and what arthritis is. So arthritis is the loss of articular cartilage. So you see there on the left, that's a chicken bone kind of opened up, a chicken joint. You see that shiny white surface there. That is articular cartilage at the ends of those two bones at that joint. And on the right side there, you see an arthroscopic picture of a camera inside of a human knee joint with the white is cartilage, articular cartilage on the end, and that tannish colored in the center, in the bottom of that, what we'll call a pothole is bone, and that articular cartilage is attached to that bone in the areas that there's still cartilage. In the area that there's no cartilage in that exposed bone, that's a loss of cartilage. And once we lose that cartilage, there's no getting it back. We can't at this time reattach cartilage in any reliable means back to that bone. That bone surface changes and it no longer receives the chondral cells, the cells that make cartilage and maintain cartilage. And so the whole system falls apart. It's not just filling that pothole with a substance. It's not like filling a pothole in the road where you can just pour more asphalt in there and pat it down and it stays. But even we know around Chicago that doesn't even stay oftentimes, and it pops back out. So no different in the knee. We can't pack cartilage back in there. It won't adhere to that underlying bone. The underlying bone is changed. There's a disease state going on there too. So the whole joint is affected when the cartilage starts to degenerate and flake away and fall apart. And that's why we can't just go back to the normal situation, and why other treatments that are trying to be brought forth, like stem cells, are currently not there yet, because there's a whole other cascade of things that go wrong inside the joint besides just that loss of cartilage. And the loss of cartilage then, those little flakes of cartilage that you can see floating around in there also irritate the other tissues around the knee, and the body mounts a reaction to that, says there's a problem here, and that's when you get pain, stiffness, swelling, and all of the symptoms of the arthritic condition. And as that advances, then you get so much pain and dysfunction that you can't live your normal life. So, and here's a cartoon of this same process with normal cartilage on the knee on the left, and a cartoon of it wearing away on the right. So when non-operative treatment fails for arthritis, that's activity modifications and weight loss and therapy and medicines and injections. And again, I'll point you back to other webinars that have been done that go through all of those plethora of non-operative means. And when we see that there's end-stage bone-on-bone arthritis on x-rays, as you can see here, there's no cartilage left here on this x-ray, both on the AP, the frontal view, and the side view with the kneecap in the front, and there's no cartilage left in that knee. Then we would recommend knee replacement surgery when everything else has failed. So I have a little quiz or question here. And here's a couple of analogies. And just think in your mind which one you're gonna pick. Is a knee replacement like this top image where we take an old, dirty, rusty hinge and put a new hinge in there? Nice, fresh, clean, shiny hinge? Or is a knee replacement like recapping a tire, putting a new surface on an old tire? So just think about which one it is. And if you answered number 2, that's right. It's really a resurfacing procedure. Knee replacement is a resurfacing. We're not cutting out the whole joint and putting a whole new joint in there. We're resurfacing the ends of the bone. We take the end of the femur bone where there's no longer good cartilage and resurface that with metal, top of the tibia, and then the plastic part in between. So it's not this scenario, which you can see. This X-ray shows this big hinged prosthesis in here, and this is an actual orthopedic prosthesis, but this is only used in tumor resections and severe fractures where we don't have any bone substrate left, or it's so broken apart that we can't use it anymore. So then we do have these hinged knee prostheses that are reconstruction options, but that is not a knee replacement as you hear about, like I'm having a knee replacement. So, and I know there's a bit of misconception, and I just wanted to clear up that a knee replacement is a resurfacing procedure. So you decided to have a knee replacement. So what's next? So basically we have done a lot over the years to get to where we are in knee replacement in 2024. And it goes along several different parts of the perioperative course. Medical optimization, anesthesia techniques, which include the nerve blocks that have been developed over the years, and then their implementation by our anesthesia colleagues. Efficient surgery that involves minimally invasive techniques, computer or technology assistance that has come online over time, our OR protocols for sterilization and our own personnel, and very efficient teamwork in the operating room. One of, I think, the biggest advancements in joint replacement and knee replacement is the blood management and the use of medicine called tranexamic acid, which we'll talk about. Our wound closure and dressing options have advanced over time, involving some technology there, and then our advanced rehab protocols. And all of these things are what have advanced us to the point where we can safely and efficiently and reliably do knee replacement surgery as a same-day outpatient procedure. It's not one of these in isolation, it's all of them together. It's not one minimally invasive technique. That's not what makes this happen. It's all of this together. So a little history of where we came from. Just 25 years ago, we were still doing 7-day inpatient postoperative pathways where you'd stay in the hospital 7 days and maybe lay in bed for the first 2 days before we started getting you up. We restricted weight bearing often for weeks. You're on a walker. And then even 12 years ago, I mean, the beginning of my practice, it was routine for everyone to spend 3 nights in the hospital, many lingering 4 and 5 days in the hospital, and then discharging to extended care facilities. And this was routine. We had blood transfusions and drains in the knee, and all of these things were going on during these days of sitting in the hospital. So what we've done over time then is to learn and to implement these various parts of the perioperative care pathway and get us to where we can do outpatient surgery now. So medical optimization, the preoperative primary care evaluation, you see your doctor, they might have you see a cardiology or a specialist, and that just sets the baseline of where your health is, if there's anything that needs to be optimized with your heart and medicines. And that's a big part of the outpatient care pathway is to make sure that all those are addressed, all those other potential medical problems are addressed, and that they're being treated to their maximum. A big part of this preoperative medical optimization is weight loss. We know that high BMI over 40 really increases your risk for perioperative complications, infection, and wound problems. And so both from the patient side and from the medical side, we should really try to optimize and modify factors that can be modified in a reasonable amount of time and in a reasonable way. And within IBJI, our ortho health program with our weight loss specialists is a great way to begin that pathway, especially if you think that you're not quite ready for knee replacement. It might be, or you and your doctor might think it's months or years down the road, or you have knee problems, but you're thinking about that, but you might have extra weights. I mean, this is probably the time to get into one of these programs and start optimizing and changing those things that can be hopefully optimized to have the best outcome once you eventually might need surgery. And that goes for weight loss. I mean, weight loss, but also smoking cessation if you're a smoker, and diabetes control. And then nutrition. I think there's more and more data coming out about nutrition and wound healing, and a lot of us surgeons integrate maybe not a mandatory program, but certainly an option for some of these nutrition packets that you take preoperatively and postoperatively in the hopes of helping healing properties in the body and just optimizing the building blocks that your body needs to heal in the postoperative period. Anesthesia advances and how we utilize our anesthesia colleagues have really vaulted our ability to do outpatient surgery. They used to just do a general anesthetic and pump in a whole bunch of narcotics, and then we would just pump in all the narcotics after surgery via a PCA where you push a little button there for days and just get narcotics until the joint got to a point where or you finally woke up enough to get out of bed, and that didn't work, and that led to a long time in the hospital. So now we're really specific about how we do anesthesia, and this is what allows you to get up and walk and go home the same day. So spinal and or general, there's some data that spinal anesthetics can be better for blood clots, but really a lot of the advanced protocols actually use a spinal, but a light general on top of it, because it really helps. They can use a shorter acting spinal that allows you to wear off so that you're right up after surgery, and then the general anesthetic helps with the surgery. Adductor canal blocks. This when I first started, they were doing femoral nerve blocks that are higher up in the thigh, and that knocks out the whole quad muscle function. So when you got up, you had to wear a knee immobilizer so that your knee didn't buckle. But now with the development of an adductor canal block, they block the nerve much farther down and just get the sensory part for the pain receptors at the front of the knee. And the quad, when you wake up, you can get up because the quad muscle works and it's not giving way, and you don't need a brace or anything. So that's been a bit of advancement. Some anesthesiologists will add another nerve block for the back, but most of us use a pain medicine injection that you see at the bottom around the back of the knee when we're inside the knee to inject a medicine and numb up the back of the knee. So that's also not hurting immediately when you're getting up. We want to limit the narcotics. We have a multimodal pain cocktail that involves a nerve medicine, some steps of lighter and heavier narcotics if needed, but then an anti-inflammatory, and Tylenol being the base of the cocktail. We give anesthesia will give IV steroids that helps with nausea and inflammation around the time of surgery. and then the IBTXA, the tranexamic acid, which is for blood loss, and we'll talk about that. So then once we get into the surgery, we want to be efficient. We want to do a quick, efficient surgery that achieves the goals of surgery, but in a fast manner, because we don't want the body and the knee open to the outside world for a long time to reduce infection. So I think that's the advantage of super subspecialization within orthopedics. You can look on our IBJI website. We have, hand surgeons and shoulder surgeons and elbow surgeons and knee and hip and foot and ankle, and we're all super subspecialized. And some people say, well, I mean, do you not like doing the same thing all day long? But I think we can focus so much in on what we're doing, and we can learn every intricacy about it, so that we can bring the best of the data and the best of what's going on to those. And so I think that's the advantage of knee and hip fellowship trained surgeons, and why we're leading the charge on outpatient surgery. I always say we want to do the same to my team in the OR. We want to do things the same way every time. We want a protocol. We want to set up the same. We want to execute the same, and having the same OR personnel and a team that works with that surgeon all the time is integral to this process. And I think in the olden days, when hospitals had a few ORs and the teams were diverse, and they would do belly and bowel cases one day and then knee replacement the next, those teams were not set up to execute knee replacement surgery in an efficient and manner to ultimately get patients up and out same day. So all of this has gone into this process. So it's the team that the surgeon has around them is integral to this, and even the instrumentation we use and the sterilization of those instruments is integral to this process. Having those instruments done and in the OR on time for the surgeries we do. A big change over the past probably 10 years here really has gained traction, and I get a lot of patients ask me about technology and robots in knee replacement, and so I'll address this. So as you can see here, multiple studies have shown that computer-assisted surgery may improve limb alignment and implant position. However, whether this affects how well you will recover and function after surgery is still open for debate. So us joint replacement surgeons are constantly looking at and evaluating new technology that's in the marketplace that these companies bring to us. Large and small studies are being done, and we haven't brought together all this data and found one particular thing that's working the best yet. I mean, certainly we want to evaluate this and eventually bring the best care to the patient, but we just can't say that any one technique is making a difference yet. So we're still evaluating these different, and there's different robot systems. And this is not a robot like the urologists or the gynecologists or the general surgeons use to do the surgery, as you might have heard of a Da Vinci robot that's super precise and it's inside and it's making micro movements to dissect tissue that's very small and delicate around critical structures in the body. Orthopedic surgery is not like that. It's much more macro level, and we're dealing with bigger structures, and we don't need that fine detail and joint replacement for movement. These are more for precise alignment and cutting, and so that's what we're trying to figure out. And there's older computer navigation that was used. That's probably going more out of favor in in favor of these robots with a cutting jig arm and a robotic arm that the surgeon holds in their hands that gives force feedback. But again, none of this is being proved yet to help outcomes, which is ultimately, maybe over time, once we have years of data, can start being ferreted out. There's handheld devices and virtual reality goggles that some surgeons are trialing, all kind of coming to the same point of trying to improve alignments and ultimate outcomes. I think what probably will merge all of these technologies together is artificial intelligence. Once we gather enough data, then the artificial intelligence computers can analyze all the data and maybe compile everything to the best way to do something. But I think we're several years off from knowing this yet. There's a good resource on the AAHKS, we call AAHKS the American Association of Hip and Knee Surgeons, AAHKS website. And I put a link here at the bottom. So there's a couple of PDFs there that really go through nice summaries of, in this case, what is computer-assisted surgery. So you might want to look that up as well. As I said, what I think is one of the biggest advancements in joint replacement surgery and that has transitioned us to the ability to do outpatient surgery is blood management. And this medicine, tranexamic acid, it stabilizes blood clots. So if you're a surgeon and you're doing a long surgery, like a 6-hour surgery, typically you make an incision and things bleed a little bit. As you know, when you cut yourself, things start to bleed. We coagulate and stop that bleeding, but it stops by itself because the platelets start activating and clotting off those little blood vessels, and your body stops that bleeding quite quickly. 15-20 minutes in the surgery, there's not a lot of bleeding, unless you're cutting bone or cutting other vessels that are bigger. But if you do a long surgery, several hours into the surgery, all of a sudden everything starts breaking open. These previously coagulated and clotted vessels start breaking open, and your surgical field starts welling up with blood. And that's because the body starts going in and going into the next phase of repair and healing and starts breaking down those blood clots. And that's what would happen in joint replacement. We would do a surgery of an hour long, but 4 hours later, this process would go on and these blood clots would break down, and then you'd start bleeding back into your joint and into your tissues. And so what this medicine has done is it stabilizes those clots for a lot longer and gets everything farther down the healing process. So we're not having this rebleeding that happens hours after surgery when you're in your room or at home and filling up the joints with blood, or as much blood as they used to. And that's why we used to have drains draining off the blood or having to give blood transfusions, because we lost so much blood, not necessarily during the surgery, but after it as well. So this has been a game changer for joint replacements, this medicine, and we're really not seeing any blood transfusions. I can't even remember the last time I gave a blood transfusion to a post-op joint replacement patient. And we don't have to donate blood. Family members don't have to donate blood for this. And then we really are not doing any transfusions. And that really has catapulted our ability to do outpatient surgery. I think wound closure is another area that's advanced and helped us to make surgery so much quicker to recover from. We've really gotten away, I think, for the most part, surgeons from staples. I think they look ugly, but they also don't seal up the skin very well, and they leak between each one of the staples potentially. So we oftentimes use a subcuticular plastic surgery-like closure, where we run a very thin suture underneath the skin that really seals it up tight, and then put skin glue over the top that seals it even more, to the point that you don't even really need a dressing on the knee, and you can shower and perform hygiene right away. And then there's also occlusive dressing, some with silver impregnation that decreases infections, and some surgeons like to use that either in addition to the glue or instead of glue. And then for special cases with extra soft tissue or poor skin closure, then we can employ these surgical wound vacs that go right onto the incision and help approximate and pull that incision together to keep it closed and healing. Our rehab protocols, of course, with the other parts of the surgery have advanced. We're getting the patients up right away, walking immediately after surgery. As soon as they're out of recovery room, you can get up and walk. Again, like I said, as soon as the spinal wears off, and it's a short-acting spinal, your quad muscle's working because the blocks we did aren't affecting the muscle function, and you can get up and walk with the therapist and even navigate stairs and learn how to navigate stairs safely before your discharge. And we sometimes start home therapy for some patients that have the therapist come to the home and start with joint mobility. But oftentimes now we even like the patients just to wait a day or two and then go straight to outpatient therapy. I think that it's a more controlled environment. There's some other machines and instruments and space to use to recover that you might not have at your home. And then we've even started into monitored home rehab devices that you can get on right away, that the surgeon can see your progress and how you're doing. They start early mobility, and some surgeons are even using some wearable tech that feeds them information about your joint motion and how much activity you're doing. So all of these things and these areas are how we have advanced to the point where we can do outpatient same-day discharge knee replacement. And the advantages of doing this are you get to go home to your familiar environment, and you have your own conveniences, your own bed, your own shower, your own bathroom, and you don't have to rely on others for to bring your food. It's just nicer to be home, and we all know when we come home from a vacation or staying somewhere else, it's just so much nicer and more convenient to be at home. And I'm sure I've never been hospitalized, but I'm sure anyone who has probably, that you can think back to that feeling of finally getting home and not being in the hospital. So to have that happen right away after joint replacement is probably ideal. You can control your own medicine. I mean, how many patients over the years have expressed their frustration to them sitting in their hospital room, pushing the button, waiting for medicines to be brought. And the nurses are doing their best, but they're taking some care of other patients, sometimes more critical than your problem. And they're not trying to make you wait, but the fact that you have your medicines written down by your surgeon and you can control them yourself is a big advantage. And the nice part, and really you might find it very interesting part, is like in the hospital, when I order a medicine and I say I can't currently in today's environment order, like, you can take 1 or 2 Tylenol every 6 hours. The nurse has to say, we have to put it in so you can take 1 Tylenol for pain 1 to 3 and 2 Tylenols for pain 4 to 6. And we have to put this all in there, and it really constrains the nurse and how you have to put it in there. And at home, we can just say, take 1 or 2, and you can decide, if you need 1 or 2. And we're prescribing, we're telling you can do it. And it's crazy that we can let patients decide for themselves under our guidance that's okay, but we can't tell a nurse that because of the powers that be and the ordering mechanisms and the regulatory environment. So I think that's another part of medication control that the patient gets empowered with that really helps the recovery. Certainly there's less infection risk when you're not staying in the hospital environment for a prolonged time. That's just kind of intuitive, and being around the hospital with other sick patients is not ideal when you're having an elective joint replacement surgery. And then there's certainly a cost savings overall, both to you, your insurance, the hospital, especially when you have high insurance deductibles and co-insurance. And so a lot a lot of the insurance pathways are actually pushing this now. And I've even heard of some insurances giving you kind of a bonus or a cash back bonus for picking certain pathways. So how do we want to prep for surgery? I think securing family and friend support is optimal. Some patients say, well, I live alone. I can't go home the same day. I don't really think that's the case. I think that if you plan ahead enough, that you should and could find some coach and a family or friend support. And I think that you're really pigeonholing yourself, wanting to stay in a hospital or go to a rehab just because you live alone. But I think putting in that effort to find some support device, people around you that could provide that so that you can optimize your care and go home. I think attending a joint class at the hospital, or sometimes even the IBJI's therapy locations have some educational classes that you can go through. And certainly our website with the webinars has resources on that. You want to prepare your home, remove loose rugs, think about what you're going to do with your pets. That goes back to number one, and family and friend supports. Maybe prepare some meals so that you don't have to worry about that in those first days that you come home. And then oftentimes we'll be able to send the prescriptions, well in advance of surgery, so you can get those all set and picked up and at home, and then make your appointments for your physical therapy. I want to remind you that when you have a knee replacement, you're not sick. This is not something that you're doing because it's a surprise, or you're going in because you're ill. You're coming in quite healthy, and because we've done all this other preoperative work, and so you don't need to stay in a hospital if you're not sick. If you have significant medical issues that might temporarily worsen because of the surgery, then of course we need to monitor those and have a plan for any contingencies of worsening medical conditions. But for the most part, I want to stress that you're not sick when you have a knee replacement. So hospitals are for sick people, and home is when you're not sick. So have a knee replacement and go home. I mean, of course, there's contraindications, and it's our job to really look at who's a candidate and not put someone into a pathway that they're not supposed to be in. So severe heart disease, congestive heart failure, poorly controlled diabetes, chronic lung diseases, chronic kidney disease, severe and untreated sleep apnea, and then certainly balance problems and neurologic diseases, Parkinson's and so forth, I would not put into the pathway of same-day discharge. And then recovery, follow your surgeons and your therapist protocols, and we all have them, and we have them posted on our website. And I think if you follow those and listen to your surgeon, your therapist, you'll go right along this pathway perfectly. You want to work on your own. You're your own best advocate and therapist, and you can't wait for someone else to come and move your knee. You have to move it. It's a joint. It's meant to move. Life is motion, and motion is life. And you have to start right away. Waiting to move a knee replacement, it might hurt, but you can't break it. And the pain will eventually go away. But if you don't have the motion there after it all heals, then it's not coming back, because that scar tissue has solidified it in its state of healing. And if that's lack of motion, then that's where it's probably going to stay. So you want to start moving and motivate yourself on your own, and then take cues from the rehab protocols and your therapist. The body does take 6 weeks to heal. I always say, whether you have break a bone, sprain an ankle, or have a knee replacement surgery, the body's tissues take about 6 weeks to heal. That's just kind of a law of the universe. And so during that time, you're going to have various ups and downs, and swelling and inflammation and pain. But it continues to improve day by day, week by week. By 3 months, you should be back to most activities. And certainly there's a lot about the last 10% improvement just during the post-operative year. Those tissues turn over. If you ever watched a scar that you might have gotten, or a surgical incision, it doesn't look the same 6 weeks out that it does a year out. That fades, it goes away. Well, if it happens on the surface, it happens inside as well. Those tissues turn over. We're constantly renewing the cells and the tissues in our body. And once it goes through a full cycle of that, about a year, everything moves better. It feels more normal. And one study even showed up to 2 years improvement. So don't fret if it's, everyone's body heals a little differently. We can't predict that. So don't fret if you're taking, several months to feel like you thought you would, because there's still improvement to be had. So that's kind of my presentation tonight, and I'm open to any questions at this point.
And Dr. Oryhon, Ryan, before you put up Dr. Oryhon's slide, Joan was asking if you could put up the slide of the knee resurfacing at the ends of the bones, showing what's placed on the ends of the bones. Would you mind popping that back up? She was wondering what that material is made out of. So Ryan, if you could give Dr. Oryhon the possibility to put things back up again. Awesome. So I think, yeah, it's further back, kind of near at the beginning, right?
Yeah. Yeah, I mean, so here's an implant. I'll show you this first. So there's a femoral part that's metal, a tibial part that's metal, and the plastic insert that snaps into the tibial part. So that's a total knee replacement. We're replacing the medial, the lateral, and the patellofemoral compartments, the 3 compartments of the knee. And so these materials are typically cobalt chrome alloy, metal alloy, titanium, or sometimes what's called oxinium, which is oxidized zirconium metal. So zirconium, cobalt, chrome, titanium, those are kind of 4 metal elements that make up most of the prostheses we use in orthopedics and certainly in knee replacement. And there's that x-ray of that resurfaced that part inserted on the bone and on the of the femur and the tibia.
Awesome, thank you very much. And then her other question was, after a knee replacement like this, will she ding in an airport?
Probably. So there's enough metal here to set off metal detectors and magnetometers. And so that can happen. You don't need a card. You don't need any documentation or proof you have a knee replacement. The TSA agents see thousands of patients a day, probably with joint replacements. You just politely walk up to them and say, sir, ma'am, I have a knee replacement, a hip replacement, and they'll tell you what to do. You don't have to flash cards or flash body parts in their face. And they'll just acknowledge it and tell you how to proceed.
Wonderful, thank you very much, and thanks, Ryan, for putting that back up. All right, okay, so let's go into some of the other questions. What are your thoughts on doing a bilateral surgery?
So yeah, I'd say we do that less often now. My thoughts are that it kind of takes you out of this protocol that has developed over time. So, we talk about going home the same day, but I think if you have both knees done, both hips done at once, like that really derails this. And it's double the length of surgery and anesthesia time. We can't use the medicines properly because if you block too many nerves, you're overdosing on the nerve block medicines. So we can't adequately put you in this pathway that we've kind of developed and proven gets you up and out very quick. So I think there's only rare instances where it might make sense to do both knees at once. Severe deformities that really are going to impact your function and recovery, we might consider it. But otherwise, I'd rather put you through a quick recovery pathway, get you up, do one knee, and come back, 6 weeks, 12 weeks later, and do the other side in the same pathway. And so that's my feeling.
Excellent, and that's great. I was going to ask you how quickly you would do it again. So 6 to 12 weeks later, they could
Yeah,
have the.
I mean, so some of the, and it sounds weird, but Medicare, we kind of have to go 90 days out because Medicare evaluates us as surgeons, and if we do another operation within 90 days of another operation, we get dinged as a bad surgeon. So they can't in their data distinguish between us deciding on the front end to do your right knee today and your left knee in 6 weeks. It just shows up as Dr. Oryhon did 2 operations on Mrs. Jones in 90 days, and he must be terrible.
Got it.
So for Medicare, we really have to push it to that 91st day. Other insurances, it doesn't matter.
Excellent. Well, and that answered the next question about Medicare coverage. So perfect. Okay, thank you. All righty. And so I think you already answered this question, but you may want to go into it in a little bit more depth. Actually, I lied. That person left, and you already answered it. So I'm gonna move on. So someone is asking, what does it mean when you talked about a muscle sparing surgery, and how would that be different from a non-muscle sparing knee surgery? Uh-oh, were you able to hear me? Oh, now I can't hear you. Uh-oh. I'm not hearing you, Dr. Oryhon. Let's see. I'm looking into it to see. We've lost your audio, Dr. Oryhon, if you can hear me. Can you hear me now? Just a minute, I'm trying to get some answers. Oh no. Oh, there we go.
Are you there?
Now I can hear you. Yep.
All right. I'm sorry. I don't know what happened.
Should I repeat the question or?
Yes, please. Yeah, I didn't get it.
Okay, excellent. So you were talking about the, what does it mean when you talk about the muscle sparing surgery as compared to a non-muscle sparing surgery?
Okay, so this is, I think, one of the least important parts of the pathway that we talked about the different reasons why we can do outpatient surgery. There is no clear data on what approach to knee replacement is better in our literature. There's kind of 3 main approaches. You can do a medial parapatellar approach, which you kind of cut up into the quad tendon a little bit, and then at the end you repair that. There's a mid-vastus approach where you preserve all the attachment of the quad muscle except for a little sliver of the inner part of the medial quad muscle. And then there's a subvastus approach where you lift up the entire quad muscle from the inside and slide it over. And like I was saying earlier about efficiency and in the operating room. I mean, really, it has to be surgeon specific and facile on how they do it. If they developed a very reproducible way to do a subvastus and lift up all of this tissue and move it over to the side, then I think that's the way they do it, and they're achieving their goal there. If they're doing a medial parapatellar approach and cutting up into the quad tendon a little bit, that tissue heals very quickly and very rapidly. And I personally haven't seen any difference in different approaches and recovery. I think all the other things we've changed and we talked about tonight are what are driving fast recoveries and not necessarily the surgical approach. I personally do a mid-vastus approach. I think it bridges the gap between the other two. But I can't in good conscience say I'm doing something better. I would call, as the parlance is, I would call it muscle sparing, but it's if I showed you in a cadaver the anatomy, we're not really cutting muscles off of bones in any of them. So yeah.
Yeah, so that terminology to the layperson sort of sounds like, ooh, wow, we're bearing muscles. But what you're saying is,
and I think early on it was important. Before we had all these other parts of the puzzle and the protocol in place, we were thinking that was going to be a major difference, but we haven't found that to be a major difference, especially in combination with the other stuff we're doing. So it's only a small piece, and really it's the piece in your surgeon's hands on how they do it the most effective and efficient way that is the most important.
And that makes sense. And you talked about that super specialization, which makes a lot of sense in advancing knee replacement surgeries.
Yeah, and all of us know those various techniques, right? I mean, it's not like there's a secret society or secret knowledge. I have colleagues who do it one way, I do it another way. But we're all kind of swimming in the same direction with it. And sometimes something comes along that's just so convincing that, everyone changes to it. But I would say surgical technique of these kind of lay terms of muscle sparing or not cutting things, there's so much nuance there that they're only a small part of recovery.
Great, thank you. That makes a lot of sense. Speaking of parts of recovery, Deborah asks, are there any exercises we should do prior to surgery to help recover faster?
Yes, I mean, oftentimes we'll send you to therapy. I mean, it's just part of your disease state, but also in preparation for surgery. And I kind of try to see the patients that are most maybe debilitated beforehand that could benefit from it. But I think just in general, quad tone is probably the best thing you can do. And you can do that with straight leg raises and partial squats or lunges if you can do them. But all those things that are difficult sometimes with an arthritic knee. But I think straight leg raises, waking up in the morning and lifting your legs straight off the bed, fully extended multiple times on each side, and then flipping to your side and lifting your legs straight to the side and helping your abductors. I think core and hip muscle strength is also very important for recovery, and that's what really holds you up when you stand. So don't neglect the hip abductors as part of that toning.
So I tell all of my clients, go into your surgery as strong as you can, and you'll come out better for it. And that's basically what it sounds like you're doing. Yeah,
absolutely.
Super. Awesome, thank you. Are there any activities that are contraindicated following surgery? So for example, someone asks, is skiing possible afterwards?
Yeah, I really don't limit my patients from anything. I mean, if they're strong and confident enough to do it, then they're strong and confident enough to do it. Certainly it's not the first thing you do. I wouldn't say you have knee replacement, and at 6 weeks, the first exercise you do is go skiing. But I think that if you're have knee replacement and then you're able to look up and do some of those, I mean, I'm a skier myself, and a couple months out from my ski trip, which I only sometimes get to take one a year, but I look up some ski specific kind of exercises to start doing, and if you start doing those and you're confident with those, then I think you're going to be fine. And you've been a skier, and you but I wouldn't start something new that you've never done right off the bat. And I would do easier things first. And so I don't have any particular restrictions in my patients, and you're going to go back to what you're used to and what you're comfortable doing. And I think the implants can hold up.
Awesome, thank you. That's wonderful news. How long would someone expect the surgery itself to take?
Surgery is about an hour, I would say. I mean, for the surgeon side of things, it's about an hour plus minus. I think that I think you can easily accomplish the goals of surgery and do a really good job in 60 minutes. If surgery takes longer, it's probably because of deformities and just the extensive nature of the problem. I mean, I don't want to. I mean, maybe there's surgeons out there that are just way better than me, but I get leery when I hear no one. I don't think in our organization or company, but when I've gone to meetings and some surgeons brag that they can do a knee replacement in 20 minutes, I'd probably stay away from that. I just don't know how you're what you're looking at and what you're accomplishing for the good in 20 minutes. That's not something that sounds good to me, because I don't think you can fully assess everything and do a good job in 20 minutes.
Gotcha. So about how many knee surgeries or knee replacements would you do in a typical day?
6 or 7. I mean, and that's sometimes a combination of hip replacements and knee replacements, but we do kind of stagger them. I do the entire operation myself. I have trained helpers that will close the skin and apply the dressings, but everything else I do. And so by staggering those, the anesthesia part can start up while you're finishing up the one operation, and then your team closes the skin, puts on the dressings, and gets you safely to a recovery room while I go and start the next one.
Gotcha, gotcha.
So with that, you can do 6 or 7, or I mean, some surgeons 8, but depending on their teams.
Gotcha. And obviously you see patients in the office as well certain days. On average, how many knee replacements do you do in a year, and how many hip replacements do you do in a year?
It's probably around 250 of each or so. Yeah, maybe a little less, 250 knees and 200 hips, something like that.
Gotcha. Wow, that's amazing. Okay, a couple more questions and then we will let you go. Is an MRI of the knee still taken to measure replacement part size before the surgery for the best fit?
So with that technology, so some of the technology uses preoperative imaging, and some of it uses intraoperative imaging. So a lot of the systems are based on 3-dimensional preoperative imaging, which would be a MRI or CT scan. And that CT scan or MRI is taken, it's converted into a 3-dimensional model by the computer system, and then we can manipulate that, both the surgeon and a lot of times the engineers at the implant companies can then manipulate that and make measurements off of that 3-dimensional image, and then feed that either into the computer that runs the robot arm, or making a custom fit block that gets manufactured, sterilized, and sent to the operation that clicks right onto your bone to take that preoperative plan and translate it to the OR. So there's a couple of technologies there that do employ MRI or CT 3D imaging. Some of the robotic systems just use, you have to register all kinds of points, and the kind of virtual eyes of the system kind of see you registering those points and then build a three-dimensional model right there in the operating room. That takes extra time. So there's pluses and minuses to each one of these technologies. But yes, like I personally use a CT scan, hip, knee, ankle. I make a three-dimensional computer model and use a custom patient-specific cutting system for each patient. So I think and this technology has been around, and why I haven't transitioned to one of the robot arms, because it, to me, gives me that alignment and fit and size data that I can translate to the operation reliably without having to bring in an expensive, cumbersome machine into the surgical field to do that during the operation. But I mean, again, all this technology we're still evaluating for its long-term usefulness.
And it's continuing to change even as you.
That's right.
As you're evaluating.
Right. And that's the whole thing. As artificial intelligence kind of analyzes this data for us too, we might just come to the best way to do it even without these specific
current technologies. Right.
Right.
Very cool. All right. Well, it is 8:01, and I told you I wouldn't keep you past 8, so my apologies on that. Everybody who still has questions remaining. Yeah, yes, exactly. But thank you. There were still other questions. So those of you who still have questions for Dr. Oryhon, please reach out to him. You've got his phone number there, his office locations. And Dr. Oryhon, thank you so much for your time. I thought it was fascinating, and clearly we had a great crowd. So thank you all for being here tonight. And Dr. Oryhon, thank you so much for your time and your willingness to share so much great information with us.
Well, thanks so much, and good night to everyone on the call. Thanks.
Good night. Thank you.
Bye.
Bye-bye.